Hello everyone, here we will be discussing various changes in the plasma osmolality, urine osmolality and sodium concentration in the various kinds of polydipsia. So first coming into central and nephrogenic diabetes insipidus. So here what happens in central there is no ADH secretions, okay, and in nephrogenic the ADH is there but is resistant because of the resistant to the receptor, means ADH is present but they are not acting on the receptor level. So in either way the action of ADH is not there. So ADH is responsible for antidiuresis, means sodium antidiuresis means water reabsorption. So facultative water reabsorption, if that is not happening, so water is not going into the intravascular space, so there will be high plasma osmolality. So water is lost through the urine, so there will be very low urine osmolality. As water contained inside the plasma is low, that can result in hypernatremia. Okay, coming into psychogenic polydipsia, here what happens, your ADH production is also good, it is also okay, and at the level of periphery it is also acting. That means at the level of receptor, that is V2, it is also acting. So the secretion and at the level of receptor, both the things are normal, but the polydipsia is happening because of intake of more than equals to 20 liter per day of water intake, because my kidney has a maximum level of water excretion threshold, that is 20 liter per day. If anyone exceeds that limit, okay, then what happens, the excess water that will be accumulated inside, so that invariably leads to low plasma osmolality as well as low urine osmolality, and there will be obviously hyponatremia. Basically this will be a kind of dilutional hyponatremia. Now in case of SIADH and CSWS, SIADH means syndrome of inappropriate ADH secretion and CSWS means cerebral salt wasting syndrome. So in both the cases the thing will be same. In SIADH what happens, syndrome of inappropriate ADH secretion, that means here in spite of having a low plasma osmolality, your ADH is still secreting, the ADH secretion is still there. Okay, ADH function is antidiuresis, means it will take up the water, reabsorb the water, but in spite of having a low plasma osmolality, still the ADH is secreting. Okay, that is happening. Normally this ADH secretion at rest is not happening, but what happens here in case of SIADH, that is why it is known as syndrome of inappropriate ADH secretion. So there will be low plasma osmolality but still ADH secretion is high. As ADH secretion is high, then more and more water will again be reabsorbed from the distal tube and collecting duct, and that will lead to a high urine osmolality. Okay, and as the plasma osmolality is low, it can result in hyponatremia.